3 years ago, a 67-year-old woman came to me for a routine cardiac procedure. She was healthy, active, sharp as a tack. Her family wasn't worried. She came out of that surgery different, not physically damaged, but something had changed, cognitively, emotionally, and no one had warned her family that this was even a possibility. I'm Dr. Kevin Adewale. I'm a cardiothoracic surgeon, and today I'm going to tell you what I wish more doctors told their patients before they ever go into anesthesia. If you are over 60, or you have a parent, a spouse, a sibling over 60, this video is for you. Because here's the truth that gets buried in consent forms and pre-op checklists. Anesthesia does not affect a 65-year-old body the same way it affects a 35-year-old body. Not even close. And I'm not talking about dramatic stories of people who never woke up. I'm talking about quieter, more insidious risks. The ones that unfold over days and weeks after the surgery is done and the surgeon has moved on. By the end of this video, you will understand exactly what those risks are, why they happen, and, most importantly, what you can do about them before you ever get to the operating room. Stay with me. This matters. Let me start with some basic biology, and I promise to keep this simple. When anesthesia enters your body, it doesn't just put you to sleep. It is processed by your liver, filtered by your kidneys, and it crosses directly into your brain. In a 35-year-old, those systems are firing at full capacity. In a 65-year-old, not so much. Here's what changes as we age. First, the liver slows down. By your mid-60s, your liver's ability to break down drugs has typically decreased by 30 to 40%. This means anesthetic agents stay in your system longer. You don't clear them as fast. So the same dose that's standard for a younger patient can become, in effect, an overdose for an older one. Second, the kidneys. Kidney function declines naturally with age. Many anesthetic drugs and their breakdown products are cleared through the kidneys. Slower clearance means longer exposure, more cognitive side effects, higher risk of confusion after surgery. Third, and this is the one that surprises people most, the brain itself becomes more sensitive to anesthetic agents. Older brains require less drug to achieve the same depth of sedation. And yet, because they clear it more slowly, they end up exposed to more of it for longer. Think of it like this. If anesthesia were a glass of wine, and I say this with all due medical respect, a 30-year-old processes that glass in 45 minutes. A 70-year-old is still feeling it 4 hours later. Now multiply that effect with intravenous drugs in a surgical setting. And this is before we even talk about pre-existing conditions: hypertension, diabetes, atrial fibrillation, mild cognitive impairment that nobody has officially diagnosed yet. All of these change the risk equation significantly. I want to walk you through 3 specific risks. Not the ones on the consent form that everyone skims, the ones your anesthesiologist might mention briefly, or not at all. Risk number 1, POCD, post-operative cognitive dysfunction. This is not a stroke. It's not dementia, but it can look like both. POCD is a measurable decline in memory, concentration, and mental processing speed that occurs after surgery. Studies suggest it affects anywhere from 25 to 40% of adults over 60 following major surgery with general anesthesia. In most cases, it resolves within weeks to a few months. But in a significant number of patients, particularly those over 70 or those with early signs of cognitive decline, the changes can persist for a year or longer. And here's what breaks my heart. Families notice it. They say, "Dad just hasn't been the same since his surgery." And often, they're right. But no one prepared them for that possibility. The causes are still being studied. But what we know is this: the inflammatory response triggered by surgery, combined with the direct effects of certain anesthetic agents, disrupts normal brain signaling in older patients in ways that simply don't happen in younger ones. Risk number 2, cardiovascular stress during anesthesia. General anesthesia causes a drop in blood pressure. In a young, healthy cardiovascular system, that drop is manageable. The heart compensates quickly. In an older patient, especially one with any degree of arterial stiffness, coronary disease, or heart valve issues, that same drop can trigger a cardiac event. I've seen it happen. A patient goes in for an elective hip replacement. During induction, before the surgery even begins, blood pressure falls sharply. The heart tries to compensate. It can't. And suddenly, what was a routine orthopedic case becomes a cardiac emergency. This is not a reason to avoid surgery when surgery is necessary, but it is a reason to have a very detailed preoperative cardiac evaluation. Not just an EKG, a proper, thorough assessment. Risk number 3, delirium and how it's being missed. Postoperative delirium is one of the most under-recognized complications in elderly surgical patients. It's characterized by sudden confusion, disorientation, and in some cases, agitation or withdrawal, typically appearing 24 to 72 hours after surgery. It affects up to 50% of older patients after major cardiac or orthopedic surgery. And alarmingly, it is often written off as just the anesthesia wearing off. But delirium is not benign. Research links postoperative delirium to longer hospital stays, higher complication rates, and an accelerated progression to permanent cognitive decline in vulnerable patients. The risk factors? Age over 70, pre-existing mild cognitive impairment, polypharmacy, meaning the patient is already on multiple medications, sleep deprivation before and after surgery, and certain classes of anesthetic and sedative agents. Knowing these risk factors before surgery means they can be managed. Certain drug protocols can be avoided. Preoperative strategies can reduce risk, but only if someone asks. Now, I am not telling you any of this to frighten you away from surgery. Surgery saves lives. Anesthesia is a medical miracle. I have stood in operating rooms for 25 years and watched both perform extraordinary things. What I am telling you is this: information is protection. So here's your action plan. Step 1, ask specifically about the anesthesia. Plan, not just the surgery. Most preoperative conversations focus on the procedure itself, which you have every right to ask. Who is my anesthesiologist? Can I speak with them before the day of surgery? What type of anesthesia will be used? General, regional, or sedation? And critically, given my age and my medical history, are there lower risk alternatives? Regional anesthesia, a spinal block, an epidural, a nerve block, avoids the systemic effects of general anesthesia entirely in some cases. For hip replacements, knee surgeries, and certain abdominal procedures, it is a legitimate option. Ask about it. Step 2, bring a complete and current medication list. Every single medication, every supplement, every herbal remedy. Because dozens of common drugs, blood thinners, blood pressure medications, certain antidepressants, even melatonin, interact with anesthetic agents in ways that increase risk. Your anesthesiologist cannot protect you from interactions they don't know exist. Step 3, get a baseline cognitive assessment if you are over 65. I know that sounds alarming. It shouldn't be. A brief cognitive screening before surgery is not an admission of weakness. It is a reference point. It gives your medical team something to compare against after surgery, and it alerts them to any pre-existing vulnerability that should inform the anesthesia protocol. Step 4, ask about post-operative monitoring for delirium and cognitive changes. Not all hospitals have formal protocols for this, but simply asking, what is your monitoring plan for post-operative delirium in older patients? Signals to your care team that you are informed, that you expect this to be watched for. And research shows that when it's being watched for, outcomes improve. Step 5, have a family member or advocate present for preoperative conversations, not just on the day of surgery, in the preparatory appointments. Someone whose job it is to listen, ask questions, and retain information when anxiety makes it hard for the patient to absorb everything being said. This is one of the most underestimated protective factors in surgical outcomes. Here is what I want you to take away from everything I've just told you. There is still, in 2024, a significant gap between what we know about anesthesia in the medical literature and what is routinely communicated to patients. Most surgeons, myself included, are deeply focused on the procedure, on the technical execution, on getting the surgery right, and we should be. But the conversation about what happens before, during, and after anesthesia in an older body often happens too briefly, or not at all. You have the right to slow that conversation down. You have the right to say, I've read that patients over 60 have a higher risk of post-operative cognitive changes. Can we talk about what that risk looks like for ME specifically? A good anesthesiologist would not be offended by that question. They will welcome it, because it means they have a patient in front of them who is engaged, informed, and ready to be a partner in their own care. And if a member of your care team dismisses that question, if they wave it off as unnecessary worry, that is information too. And it is worth seeking a second opinion. Aging is not a disease. It is a process. And like any process, it can be understood, prepared for, and managed well. If you or someone you love is facing surgery in the coming months, I hope this video gives you not fear, but clarity. The questions to ask, the conversations to initiate, the things to know before anyone puts you under. Because the patients who do best, at any age, are not necessarily the healthiest. They are the most informed. If you found this video useful, please share it with someone over 60 in your life. They may not know to look for this information. And the window to act on it is before surgery, not after. I'll leave a link in the description to a pre-surgery checklist you can print and bring to your next medical appointment. Take care of yourself. And don't be afraid to ask the hard questions. That's what doctors are here for. I'm Dr. Kevin Adewale. I'll see you in the next video.